Bismillahirrahmanirrahim. Today my topic of presentation is tuberculosis. Don't judge each day by the harvest you reap, but by the seed that you plant. Learning outline of today's presentation is introduction of tuberculosis, epidemiological triad, chain of transmission, clinical features, preventions, WHO response and various strategies, TB control program in Pakistan, some recent advances and MCQs. Learning outcome. By the end of this presentation, participant will be able to describe the introduction, epidemiological triad, chain of transmission, clinical features, prevention, WHO response, and TB control program in Pakistan. Introduction. Tuberculosis is a bacterial infection that spreads from inhaling tiny droplets from the cough or sneeze of an infected person. It mainly infects the lungs, but it can also affect any part of the body, including the abdomen, glands, bones, and nervous system. It is actually a potential serious infectious disease that mainly affects the lungs, and once rarely in developed countries, tuberculosis infection began increasing after 1985, partly because of emergence of HIV, the virus that causes AIDS. HIV weakens a person's immune system so that it fights the TB germs. The World TB Day tuberculosis is celebrated on 24 March. Some key effects and of the tuberculosis to WHO. A total 1.5 million people died from TB in 2020. TB is the 13th leading cause of death and second leading infectious killer after COVID-19. In 2020, an estimated 10 million people fell ill with TB and 5.6 men, 3.6 women. In 2020, 1.1 million children fell ill with TB globally. Child and adolescent TB is often overlooked by healthcare providers and therefore can be difficult to diagnose and treat. And 2020, the 30 highest burden of TB countries accounted for 86% of new TB cases. And 8 countries count for two-thirds of total, with India leading the count, followed by China, Indonesia, Philippines, Pakistan, Nigeria, Bangladesh, and South Africa. MDR, which is multi-drug resistant TB, remains a major concern, and out of 1, 3 people with drug resistant TB cessed treatment in 2020. Globally, TB incidence is falling at about 2% per year, and between 2015 to 2020, the cumulative reduction was 18%. This was over halfway to end strategy milestone of 20% reduction between 2015 to 2020. Globally, close to 1 TB affected household faces costs higher than 20% of their household income. And following in low and middle income countries that account for 98% reported TB cases fall far short for what is needed. And there was also 8.7% decline in spending between 2019 to 2020. But the ending the TB epidemic by 2030 is among the health targets of United Nations Sustainable Development Goal. Epidemiological triad, if we see agent involved in environment relationship, agent is the tuberculosis, mycobacterium tuberous bacteria. Host factor include the weak immunity or non-immune, poor nutrition, environmental factors such as crowding conditions, poor ventilation, poor socioeconomic status, bad sanitation, bad environmental conditions, and poor ventilation are some factors. Incubation period is time from the recipient of infection to the development of positive tuberculin test, which is ranges from 3 to 6 weeks. The development of disease depends upon the closeness of contact, extent of disease sputum positivity, and thus the incubation period may be weeks, months, or years. Period of communicability. Bacilli survive in droplet for 8 to 10 days, and patients are infective as long as they remain untreated. Portal of entry. The commonest point of entry of tuberculosis bacteria is nose and throat and mouth. If we see the classification of tuberculosis, it is divided into pulmonary and extrapulmonary TB. Pulmonary TB is further divided into primary disease and secondary disease, and extrapulmonary with include lymph node TB, pleural TB, TB of upper airway, skeletal, genitourinary TB, pericardial, genitourinary TB, tuberculosis with meningitis, and other less common forms. The primary tuberculosis, which is primary exposure, is characterized by bone complex and consists of subpleural fissure focus of inflammation, infected lymph node draining the primary subpleural region. Whereas secondary pulmonary TB is actually a reactivation characterized by focus of infection and granuloma formation, usually in the apex of lung. And the small granulomas eventually coalesce to form larger areas of consolidation. with central caseating necrosis. Progressive pulmonary TB, primary or secondary TB may go on healing as caseating normal placed by fibrosis and calcification. However, cases do not heal spontaneously with therapy and progress from cavitation and spread to other parts of TB through bloodstream, which is known as miliary tuberculosis. Tuberculosis. A person may develop TB after inhaling Mycobacterium tuberculosis bacteria primarily from person to person. When TB affects the lungs, the disease is the most contagious. But a person will usually only become sick after close contact with someone who has this type of TB. Now, how TB spreads? TB spreads through air. TB spreads from person to person with someone with contagious TB coughs, speaks, or sings. TB is not spread by sharing toothbrush, saliva from kissing, shaking someone's hands, touching bed linens or toilet, shaking food, drinks, or utensils. Now there is also latent tuberculosis infection and TB disease. Latent TB infection is actually the people with latent infection that do not feel sick and don't have symptoms and cannot spread the TB. And TB jumps to others and can have latent TB infections for years. They have actually a small amount of TB jumps in their body that are alive but inactive. Latent TB infection can develop into TB disease. TB disease, if TB germs become active and multiplied, latent TB infection can turn into TB disease. If we see the difference between latent TB infection and TB disease, TB infection has small amount of TB germs uh, alive but inactive, whereas TB disease has a large amount of active TB germs in our body. TB infection cannot spread TB germs to others, whereas TB disease spread to others. Infections to TB germs. TB infected person do not feel sick but may become sick if germs become active. The TB disease person feels sick and symptoms of cough, fever, and weight loss. Latent TB infection usually have positive TB skin test or TB blood testing results, whereas TB disease usually have positive skin test or blood test resulting indicating TB infection. Latent TB infection should consider treatment for latent TB infection to prevent TB disease, and a person with TB disease needs treatment for TB disease. Untreated latent TB infection can lead to TB disease if the immune system of the person cannot stop TB germs from growing. And most people diagnosed with TB disease in the become sicker after living with latent TB infection. And latent TB infection treatment is 90% effective in preventing the development of TB disease. Possible TB disease symptoms include night sweats, fever, chills, weakness or fatigue, weight loss, no appetite, cough lasting longer than for 3 weeks, pain in the chest, coughing up blood or sputum. Symptoms of active and latent TB. Active individual have any disease with TB disease may experience a cough that produces phlegm, fatigue, a fever, chills, and loss of appetite and weight, and symptoms usually worse over time. Whereas latent TB, a person with latent TB has no symptom and no damage will show on a chest X-ray. However, blood test or skin prick test will indicate that they have TB infection. Early warning sign: a person should consult a doctor if they experience persistent cough lasting for 3 weeks, uh, sputum which may have blood in it when they cough, a loss of appetite and weight, a general feeling of fatigue and unwell, swelling in the neck, a fever, night sweats, and chest pain. Public health workers are responsible for fighting TB contact. A TB contact is a person exposed to someone with contagious TB disease. Contact can include family members, roommates, housemates, close friends, co-workers, classmates, and other. People with TB disease can spread TB germs to others. The local health department will conduct a contact investigation by follow-up and testing those who have been close to someone with TB. Beyond the lung, TB usually affects the lung through symptoms that can develop in other parts of body. This is the most common in people with weakened immune system, such as HIV patient and cancer. TB can cause persistent swollen lymph nodes, such as swollen glands, abdominal pain, joint or bone pain, confusion, persistent headache, or seizures. Risk factor. Anyone can have TB, and but someone people who are high risk of getting TB include people who have contact with someone who has infectious TB, people who are born or frequently travel to countries where TB prevalence is high, and healthcare workers who work or live in places which are high risk of tuberculosis. Tuberculosis mostly affects the adults in their most productive age group, which are all age group at risk. However, 95% of cases and deaths are occurring in developing countries. And people who are infected with HIV are 18 times more likely to develop TB. And the risk of active TB is also greater in persons suffering from other conditions that impair the immune system. But in HIV, it is 18 times more to develop TB infection. Alcohol use, soda, and tobacco smoking also increases the risk of TB by factor by 3.3% respectively. Therefore, people who are developing the TB generally divide into two categories: those who are recently infected with TB germs or those with medical condition that weaken the immune system. It includes HIV infection patients, substance abuse, specialized treatment for rheumatoid arthritis, Crohn's disease, organ transplants, severe kidney disease, low body weight, silicosis, medical treatment such as corticosteroid, diabetes, patient head or neck cancer. Complications. Tuberculosis complication includes spinal pain, back pain and stiffness, joint pain, when usually include the joints, for example, tuberculosis arthritis, swelling of membranes when they cover the brain, meningitis, which can include intermittent headache, liver or kidney problem when they invade the liver and kidneys, which help filter waste and impurities from your bloodstream, and heart disease. Rarely, tuberculosis can infect the tissues that surround your heart, causing inflammation and fluid condition that might interfere with your heart ability to pump effectively. This condition is called cardiac tamponade. Now, level of prevention of airborne infection, especially the level of TB prevention. Prevention, primary prevention of preventing TB, then intervention include infection control measures in health setting to prevent transmission to patient and staff. And secondary prevention preventing TB disease include INH therapy. Early diagnosis and treatment include INH therapy to prevent progression to tuberculosis treatment. Intensified case finding, early diagnosis and treatment. Tertiary prevention include preventing TB morbidity and mortality, which include BCG vaccination. Does not interfere in prevent infection TB, but does prevent severe form of childhood TB. Diagnosis and treatment before complication develop. Therefore, symptoms and diagnosis. A common symptom of active TB are cough with sputum, at times chest pain and weakness. WHO recommends the use of rapid molecular diagnostic test as the initial diagnostic test in persons in signs and symptoms of TB, as they have high diagnostic accuracy and will lead to major improvement in early detection of TB. Diagnosis: multi-drug resistant TB include HIV associated TB can be complex, expensive. Therefore, tuberculosis is particularly difficult to diagnose in children, and rapid tests are recommended by WHO's gene expert IF Ultra and TrueNet assays. TB testing. Two types of testing can be used to tuberculosis: TB blood test and TB skin test. If either both tests is positive, further tests are confirmed to diagnose of TB, which in medical examination or also chest X-ray. When TB blood test is done and sent to laboratory analysis, positive blood test, a person likely has been infected with TB germs, then additional tests are needed to determine. Negative blood test include person did not react to TB test and latent TB infection. And the TB blood test is also known as interferon gamma release assay. TB skin test. The TB skin test is also government talks for clean skin test, which require two visits with a healthcare provider. On the first visit, the test is placed, and on the second visit, the test is read. People vaccinated with BCG can still get the TB disease. BCG is a vaccine for TB and is often given to infant and small children in countries where TB is more common and protect against severe form of TB in children. TB blood tests are prevented for people who have received TB vaccine. The TB vaccine may make a TB skin test hard to interpret. The TB vaccine does not affect the TB blood test result. Therefore, TB blood tests give more accurate results in people who have received the TB vaccine. Because skin test can interfere with interpret to read the interpret. Therefore, TB blood test more accurate results in people who have received TB vaccine. Treatment. Treatment for latent TB infection can prevent the development of TB disease. TB germs in body of someone with latent TB infection inactive. People with latent infection should take medicine to prevent the development of TB even they don't feel sick. Treatment include first-line drug which include isoniazid, rifampicin, ethambutol, pyrazinamide, streptomycin. Second line include ethionamide, cyclosporine, tetrachlorphazimine, mecacin, capreomycin, kanamycin. There is also novel generation anti-TB, proteomanamide, beta-quinoline, and delamanid. How latent TB is treated. The most common preventive therapy is a daily dose of INH taken as a single daily pill for 6 to 9 months. And active TB tuberculosis include combination of antimicrobial drug for period of 6 to 12 months according to WHO. The most common treatment for active TB is INH in combination with three other drugs: rifampicin, pyrazinamide, and ethambutol. Drug resistant TB means that some drugs initially used to treat TB are no longer to fight against drug. The treatment for this type is takes 20 to 30 months to complete. And managing TB, when you are in treatment for active TB, you need regular checkup to make sure the treatment is working. And there are also side effects taking medicine. For example, there is upset, nausea, vomiting, stomach tingling, itchy skin rash, changes in eyesight, blood vein, yellowish skin, dark colored urine, weakness, or fatigue. It is important to tell your doctor or TB nurse immediately if you begin having unusual symptoms while taking medicine or either preventive therapy. Vaccine. TB BCG vaccine is bacilli calmette variant. Its efficacy 0 to 18%. It is dilute used for BCG vaccine in normal swine and should be given to all healthy infants as soon as possible after birth, unless the child presented with symptomatic HIV infection. Vaccine is two types vaccine, liquid flash vaccine and freeze-dried vaccine. Freeze-dried vaccine is more stable preparation, stable for several weeks at ambient temperature. A dosage for vaccine, the usual strength is zero point 0.5 milligram in zero point 0.1 ml volume, and the dose to newborn age is 0.05 ml below 4 weeks. Administration, the standard procedure recommended by WHO is to inject the vaccine intradermal using super clean syringe. There is also phenomena after vaccination. A papule well reaches a diameter of 4 to 8 millimeter, then subsides with crust healing occurs with 6 to 12 weeks, leaving a permanent tiny round scar. Vaccine complications include severe ulceration, suppurative lymphadenitis, osteomyelitis, disseminated disease infection. And the protective duration of protection is from 15 to 20 years. Contraindication of BCG vaccine: generalized eczema, infective dermatosis, hypogammaglobulinemia, deficient immunity, suspected congenital immunodeficiency, patient under immunosuppressive treatment or pregnancy. And in the EPR immunization of Pakistan, the BCG given at childhood below 4 years of age, intradermal route soon after birth. WHO response of TB. There is also case definition revised by WHO reporting of tuberculosis. For example, case definitions: bacteriological confirmed TB is one whom a bacteriological specimen is positive via microscopy or culture or gene export. A clinically diagnosed TB who does not fulfill the criteria of bacteriological confirmed but has been diagnosed with TB when medical practitioner basis on X-ray abnormalities, suggestive histology, or extrapulmonary cases. It further bacteriological clinically divided onto the anatomically side history of previous treatment, drug-resistant HIV status. Pulmonary TB refers to any bacteriological clinical form involving the lung parenchyma, and extrapulmonary refers to which can involve the organ other than the lungs, for example, pleura, lymph node, abdomen, genitourinary tract. Classification based on HIV status: HIV negative TB patient refers to bacteriologically confirmed or clinically confirmed TB who has a negative result from HIV test conducted at the time of diagnosis, and HIV positive include which have HIV positive state, unknown state. TB refer to TB patient who has no result of HIV testing and no other documented evidence of involvement in HIV care. A classification based on drug resistant, mono-resistant, resistant to first line anti-TB drug, poly-resistant, resistant to more than one first line drug anti-TB, a multi-drug resistant to at least both INH and rifampicin, extensive drug resistant, resistant to any fluoroquinolones and to at least one of the second line injectable drugs. Rifampicin resistant, resistant to rifampicin detected using phenotypic or genotypic method with or without resistant to other TB. These categories are not mutually exclusive, and while enumerating rifampicin-resistant TB, for instance, MDR extensively are also included by WHO. Classification based on history: new patients have never been treated for TB or having TB for less than 1 month, previously treated which have received 1 month or more anti-TB drug in the past. They are further classified: relapsed patients who were previously treated for TB were declared cured or treatment completed at the end of their most recent course of treatment, are now diagnosed with recurrent episode of TB. Treatment after failure patients are those who were previously treated with TB and those treatment failed at the end of their most recent course of treatment. Treatment after loss to follow-up have previously been treated with TB and were declared loss to follow-up at the end of their most recent course. And other previously treated patients are those for TB but whose outcome after the most recent is unknown or documented. Patients with unknown previous TB history do not fit any of these categories listed above. TB and HIV according to WHO. People living with HIV are 18 times more likely to develop TB TB and HIV combination are lethal and ending in progress. In 2020, 215,000 people died of HIV-associated TB. WHO recommended 12 commonest approach of collaborative TB HIV activities, including action for prevention, treatment of infection, and disease to reduce death. According to WHO, multi-drug resistant TB, anti-TB have been used for decades, and drug-resistant emergency and anti are used inappropriately. And MTBR-TB is a form of TB caused by bacteria that do not respond to INH and rifampicin, and two most effective first-line drugs. And therefore, according to WHO, the treatment success rate MDR was 40-59%. In 2020, WHO recommends a shorter 9 to 11 months oral regime for patients with MTB. And this research have shown that patients find it easier to complete this regime. And in accordance with WHO, reduction of MTBR requires bacteriological confirmation of TB and testing for drug resistance using rapid molecular test. Catastrophic cost. WHO and TB strategy target of no TB patient and their household facing catastrophic cost as a result of TB disease monitored by countries and WHO. According to the result of 23 national surveys or cost faced per TB patient, the percentage facing catastrophe ranged from 13 to 19%, and pooled average weighted for each country number of notified was 47%. Investment in TB prevention, diagnosis, and treatment and such according to WHO, in low and middle income countries accounting for 98%. TB funding is back to the level of 2016 with 8.7% drop. And over the past decade, US $0.9 were invested annually in TB by international donors. And United Nations government is the largest contributor of funding to Global Fund and the largest bilateral donor. Provisional data for TB funding in 2021 suggests that allocation for TB will remain inadequate, and for research and development, WHO, according to Treatment Action Plan, only 0.9 billion were available in 2019, and this need to accelerate the development of new tools. Global commitment and WHO response. Over 26 September 2019, UN and United Nations held its first ever level meeting on TB, elevating discussion and status of TB epidemic. And it is hosted by WHO and Russian government in November 2017. The STD target 3.3 includes end the TB epidemic by 2030 and end TB strategy defined milestone in 2025 and target for reduction in TB. The target for 2030 are 90% reduction in number of TB tests and 80% reduction in TB incidence rate. The milestone for 2020 are 35% reduction and a 20% reduction in TB incidence rate. This strategy also includes a 2020 milestone that no TB patient and their household face catastrophic cost as a result of TB disease. As I requested in political declaration, the WHO is supporting countries to adapt and use the framework to translate commitment into action. In 2020, a progress report of United Nations was developed and released, and these include high-level leadership and multi-sectoral accountability. And TB initiative, including a stake of India, Indonesia, Pakistan, Philippines, and Vietnam, as well as national campaign to drive progress such as to end the TB. WHO is also working closely with other countries in partnership to end TB through strategic development, critical and multi-sectoral involvement, setting the form and standard of TB prevention and care, developing and promoting ethical and evidence-based policy, ensuring the provision of specialized technical support to member states, monitoring and reporting on status of TB epidemic and progress. According to WHO, treatment for TB disease in pregnancy, untreated tuberculosis disease present a greater hazard to pregnant women and her fetus. Infant born to women who untreated TB may be lower birth weight than those without tuberculosis. Therefore, pregnant women treatment for latent tuberculosis can be delayed until 2 to 3 months postpartum toward administering unnecessary medication. Treatment include latent TB infection, 4-month regime of rifampicin, 3 months daily regime of INH, or 6 to 9 month daily regime of INH. In latent TB infection, in TB disease, the preferred treatment of INH, rifampicin, and ethambutol for 2 months, followed by INH and rifampicin for 7 months. Streptomycin should not be given to pregnant women. HIV-related TB disease, pregnant women, treatment of TB disease for pregnant women co-infected with HIV should not be the same for non-pregnant women, and it also be according to some guidelines. Contraindication: the following anti-tuberculosis drugs are contraindicated in pregnant women: streptomycin, kanamycin, and mecacin. Breastfeeding should not be discouraged for women being treated with first-line anti-tuberculosis drug because the concentration of these drugs in breast milk are too small to produce toxicity in nursing mother. Breastfeeding women take INH should also take pyridoxine supplementation. There is also TB and strategy for indicator, and the VN is 0 deaths disease and suffering from TB, and target is to reduce that 2030 by 90% reduction in TB deaths, 80% reduction in TB incidence rate. And there is zero TB factory family is facing catastrophic, which is a TB and strategy by WHO. Pillars and include integrated patient-centered care and prevention, bold policies and supportive system, and intensified research and innovation. This is actually the DOTS target. There is also TB control program in Pakistan, which shows various burden of TB total TB incidence according to recent estimate burden of Pakistan TB is that 573,000 number, or there is 259 incident per 1,000 population. Total TB incidence in HIV positive TB incidence there is 6.2 per 1,000 population. And universal health coverage and social protection in 2020 is 48%, and TB case fatality ratio is 8%. The treatment success rate, the new and relapse cases registered in 2019 according to National TB Control Program Pakistan is 93%, and previously treated cases relapse registered in 2019 is 85%. Profile of tuberculosis, which is C data, 567,000 people fell with TB in 2020, and which are 45% men and 41% women and 14% children. And there is 48% coverage of TB treatment according to 2020, and success rate is 93%. This is actually the goal, which is an tuberculosis strategy. Recent advances, there is a paper published in tuberculosis and COVID-19, a review of biological and clinical public health facts. This paper state that the available evidence on clinical facts that COVID-19 happened regardless of TB occurrence either before or during after TB diagnosis. And similarly, the potential role of drugs prescribed during initial phase to treat TB, COVID-19, their interaction with anti-TB regardless risk of morbidity and mortality. Several risk factors for COVID-19, intermittent risk factor for TB, including among others age, poverty, malnutrition, and comorbidity among both TB and COVID-19 infection. There is also a paper published among association, and which paper aim to test the association between diabetes and tuberculosis. This is actually the match case control study in Tertiary Hospital 2019 to 20, and this result shows that the overall cases and 45 to 20% were diabetes, respectively. Association between this factor and tuberculosis estimated positive association were found, and this study proves the evidence for strong positive association between tuberculosis and treatment. Rapid point of care diagnostic test for tuberculosis. Point of care testing for TB encompasses a test of people admitted to hospital, testing of people attending a peripheral, or testing people in community based setting at home. This identified that diagnostic technologies that are suitable for use in these contexts, and depth observation of MTB by microscopy remains a primary diagnostic method for TB in much of the world. While limitation include inability to discriminate between MTB and other known MTB microbacteria. Therefore, expert MR Ultra has been developed as next generation assay to overcome some of limitation of original expert MTB, and line probe assays are also rapid molecular diagnostic tests that can detect MTB and drug resistance. Now come with multiple choice question. MCQs 1. TB is an infectious disease that mostly affects the lungs. The causative agent that causes tuberculosis are communicated from person to person by minute droplet discharged into air by cough and sneeze. Alpha Clostridium difficile, beta E. coli, C. methicillin resistant, delta M. TB, or E. Salmonella.
D.
Delta will be correct option. MTB. MCQs 2. TB infection control is set of measures designed to reduce the risk of transmission within ABC population. MTB can be transmitted through which route? Alpha airborne route, beta comite, C vector-borne, delta oral, or E zoonotic transmission.
A.
Alpha will be the correct option. MTB can be transmitted through airborne route. MCQ3. Patient A is 30 years old who has admitted to hospital from home after suffering from week of cough, expensive nocturnal sweating, loss of appetite, hyposomnia. The patient has history of IV drug abuse and has been diagnosed with hepatitis B. Chest X-ray shows consolidation. The following is the most common cause of this condition: alpha actinomycosis, beta aspergillosis, C constrictive pericarditis, delta histoplasmosis, or E tuberculosis.
E.
E will be the correct option as patient has 3 weeks history and all chest X-rays show consolidation. Therefore, the correct option is tuberculosis. MCQs 4. When bacteria become resistant to drugs used to treat TB, drug-resistant tuberculosis can develop. Drug-resistant TB is transmitted in the same way than drug-susceptible TB. This type of TB takes longer to treat and take at least dash months to complete the treatment. Alpha 9 months, beta 6 months, C 3 months, delta 20 to 30 months, and E 2 months.
D,
alpha,
Delta will be the correct option as the drug-resistant TB, according to WHO, at least require 20 to 30 months for treatment to complete. MCQs 5. When people live and work in crowded and poorly ventilated surroundings, tuberculosis can spread swiftly. TB is 18 times more prevalent in those who are infected with dash, alpha, common cold, beta, diphtheria, C, giardiasis, delta, HIV, AIDS, or E, infectious mononucleosis.
D,
alpha,
Delta will be the correct option according to WHO. Tuberculosis is 18 times more prevalent in those infected with HIV or AIDS. MCQ 6. In XYZ community, patients with relevant clinical manifestations such as cough for lasting for 2 weeks, night sweats, weight loss, fever are suspected of having pulmonary TB. People had received the TB vaccination in the past. Which test is more accurate results in people who have received the TB vaccine? Alpha blood test, beta bronchoalveolar lavage, C chest X-ray, delta culture of sputum, E lung biopsy.
C,
Alpha will be the correct option as I already mentioned in WHO when the people have received the TB vaccine, therefore the more accurate test will be the blood test. Therefore, alpha will be the correct option. MCU 7. When antibodies were first introduced to treat TB in 1940s and 50s, the number of cases in XYZ countries started to fall. However, the number of TB cases began to climb after 1985, which epidemic was a major contributor to increase in TB infection in XYZ country after 1985. Alpha Ebola, beta HIV, AIDS, C plague, delta yellow fever, or E Zika virus.
B,
B will be the correct option. 1985 HIV is a major epidemic which affects the increase in tuberculosis infection. MCQ's 8. Patient XYZ is 35-year-old who has admitted to hospital after experiencing a lot of cough, profuse nocturnal sweating, and loss of appetite. TB was diagnosed after he was seen by emergency room physician. Patient was prescribed INH, rifampicin, pyrazinamide, and ethambutol 7 days a week for 8 weeks, then INH and rifampicin 7 days a week for 24 weeks. In this scenario, what will be the level of TB prevention? Alpha primary prevention, beta primordial, C quaternary prevention, delta secondary, or E tertiary prevention.
D,
D,
Delta will be the correct option as patient is diagnosed and treated, which is come at the level of secondary prevention. Therefore, delta will be the correct option. MCQs 9. A 39 years old HIV man from Uganda has recently immigrated to US and is being evaluated at clinic. He was diagnosed with HIV shortly after arriving in US. He is asymptomatic and interferon gamma release assay is ordered as part of the initial evaluation to check for latent tuberculosis infection. The result come back is negative after few days short. That alpha patient blood did not react to test and TB disease is not likely. Beta, he has had MTB tuberculosis for indefinite period of time. C, she has also been exposed to MTB but is unlikely to have active disease. Delta, she is most likely to receive the BCG vaccine more than 10 years, which stimulated post reactivity. E, the likelihood of TB infection, the patient cannot be determined by the test results.
alpha,
Alpha will be the correct option as the interferon gamma release assay is ordered for initial evaluation to check for latent tuberculosis infection, and the result come negative when the patient blood does not react with the test and TB and which shows that the TB disease is not likely. MCQs 10. Point of care tuberculosis testing include testing people admitted to hospital or testing people at peripheral clinic or testing people in a community setting or at a home. Which of the following technology is suitable to point of care testing program in which treatment decisions are made during the same visit in XYZ tuberculosis treatment campaign? Alpha bronchial velar lavage, B chest X-ray, C culture of sputum, delta lung X-ray, or E expert MTB or RIF alpha.
C,
C,
E will be the correct option as already mentioned in recent passage that point of care tuberculosis test is actually the test which are given people at a peripheral or any time setting and home. And treatment is made at the same time during the visit. And gene export or RIF alpha according to WHO is point of care tuberculosis testing people. Therefore, E will be the correct option. All other options not fall in this category. This is a key of my MCQs and thank you.
Thank you very much, Dr. Khadsa. Very nice presentation, very well elaborated on a very important topic. As we know that tuberculosis is giving still a challenge to humanity, and its treatment regime, it has been changed over time. Now, the latest, after the introduction of latest medicines, as you have shown in one of your slide, the total span and duration of treatment, it has been changed marvelously, as well as the preventive strategies, it has been increased many folds. We have also seen over the years that there are the decline in the number of the cases of tuberculosis, especially in developed countries, but with the re-emergence of HIV, we are again having more cases of tuberculosis. Next important thing is the duration, as it is always good in recent advances to present what are the latest advancements. And one of the key element is that after the introduction of the important drugs, the treatment duration has been decreased to 4 months almost. And even tuberculosis classification by WHO has shown the treatment duration from 6 months and so on. We know that the major challenge is by the multi-drug resistance and extended drug resistant tuberculosis. The multi-drug resistant tuberculosis, we know that the second line drugs has to be added. As the first line, they are showing, especially rifampicin and INH, they are showing resistance. While in extended drug resistance, there is an extensive part of treatment that duration is even sometimes was more than 15 months to 2 years. However, after the introduction